Thank you for being here, spending some of your Saturday with us. Okay, does this thing work? It does. All right. Okay, so we can go ahead and get started. Wanted to start out with a quote slash kind of reflection. Felt like this is fairly a good one to start with. It is very relevant to what we are doing with our rural track programs. So of all of the forms of inequality, injustice in healthcare is one of the most shocking and inhumane, said by Dr. Martin Luther King Jr. So our mission statement, you can find this on our website. This is the Family Medicine Residency Mission Statement for Creighton, Phoenix. So it is 3 parts, bullet pointed on our website. So we aim and we have a mission to provide high quality health care for our patients and their families with personal attention to their physical and emotional needs. We want to create a center of academic excellence that promotes patient care and physician learning in a supportive, collaborative environment. And we want to train a diverse physician workforce to serve our community. So that's our Phoenix mission statement, but our rural track mission and goals are pretty much the same. It's just expanded a little bit. So we want to train compassionate and highly skilled physicians. And we want to train these physicians to be somebody who's going to be committed to serving our rural and underserved communities in Arizona. So we want them to not only provide excellent care and full spectrum care, but we want them to lead with a purpose, advocating for health equality, just like that quote had said. Inequality in healthcare is one of the most unfortunate. So this is our goal in our residents that we are training here. So a lot of this is kind of going to be introductory, since I know that we were working very closely with Mariposa, and a lot of this is going to be duplicate for you. You probably already know some of it, but since we have a bigger group here today, just wanted to kind of start with the basics. So why rural training matters. Those of you who work in a rural setting they know better than anybody, but rural communities face higher chronic disease burden, limited access to care, a workforce shortage, obviously, which is what we're trying to help with. Physicians trained in rural settings are more likely to stay in the rural settings. And so that is our goal, is to train our residents in our rural programs and for them to stay and serve their communities. And then it supports health equity and access. So these are our sites. So obviously you can see us here in Phoenix. Globe at Copper Valley is going to be one of our sites, and then Nogales, Mariposa. So we are spread out across the southern Arizona area, but some statistics for you. So the Phoenix metro area is about 5 million people. Nogales is about 20,000, and Globe is about 7,000. And so obviously smaller population, but bigger need for healthcare, because if you look at the ratio of primary care doctors to the population, Phoenix, it's about 1,200 to 1,500 to 1 primary care doctor. Nogales is actually similar. And then Globe is hurting for PCPs. So 6,000 to 1 for primary care. And so we are really trying to make that number go down a little bit. And obviously this ties into just like the PCP shortage across the country. But we're trying to make our dent here in Arizona in our rural communities. So our goals, we want to develop full spectrum, broad scope clinicians so that they can serve in those settings where resources might be limited, where you might not have access to all of the specialties and the procedures that you might in Phoenix. We want to prepare them to be leaders in their communities. We want to address the social determinants of health. And so we're really going to focus on the rural health disparities and the access gaps. And we want to foster long-term commitment to rural practice. So why is rural training unique compared to the residents who are training here in Phoenix? Like I said, the clinical scope of practice in rural settings is much wider. Here, you can actually kind of like find your little niche and do something very specialized within family medicine if you want to. Not that you can't do that in rural settings, but the need is truly for more of that broad spectrum. So rural family docs work in the clinic, they work in the hospital, they work in the emergency department, they work in urgent care. Some of them have procedural privileges for colonoscopies, for circumcisions, for vasectomies, all sorts of things. And so we're really filling a gap that is needed in these communities. We want to have that continuity of care. So in smaller towns, you know, a lot of people know each other, but the continuity of care and that patient-doctor relationship is extremely important. And then resource stewardship and adaptability. So obviously you want to use what you can, but being mindful of what you do have and what you don't. And then addressing the workforce shortages. So the role of our faculty, so you all at our table over here are going to be faculty with us or already are. So you're the clinical educators and the mentors of the residents that will be coming in. You're role models for the rural patient-centered care. Some of these residents may or may not be from rural settings, and so they might need somebody to kind of show them what it means to be a part of a rural community. You're going to be the teachers for the procedural and full scope care, and you're going to help them support their growth, their confidence, and their identity. So faculty, you're going to have a huge impact on the workforce development because they're going to go through their 3 years with you guys, and kind of their experience at their program is going to shape what they do after, and what their decisions are is where they want to practice. So shaping resident career choices towards the rural practice, making the model of sustainability really for rural practice, and wanting to inspire that commitment to underserved communities. We do that here in Phoenix too, obviously. We serve our urban underserved at Creighton Phoenix here, but kind of expanding that to inspire a commitment to the underserved in our rural communities, and then strengthening that physician workforce. So that was just kind of the intro. So rural track structure and design, some of you are going to know this already because we worked really hard on it. And so just to get started, so rural track model. So we have 999 in our residency here in Phoenix, currently 988, but it will be 999 eventually. We'll have a 222 program in Nogales, a 222 program in Globe. So total for our family medicine residency for Creighton Phoenix, our family is going to be 13, 13, 13 once we're all off the ground and running. So we're going to be graduating hopefully 13 residents a year that want to serve in underserved areas, whether that's in Phoenix or whether that's in our rural communities. So the residents are going to match into the rural track. We will be starting to recruit for that next year, this coming year, starting in September. There's going to be continuity across all 3 years. So we're not doing a 1-2 model. We're doing all 3 years in our rural settings to help kind of foster that relationship and the continuity of care over those 3 years. So those residents know that these are the people I'm caring for. This is my community for 3 years, and they can have their patient panels across those 3 years. The training will include some urban academic center rotations. This is where they're going to get some of the exposure to the specialties, the more sub-specialized things, and some more numbers. So sometimes we might have to have them come here just to get more patient numbers. The rural site, obviously, that's their longitudinal training. And really our goal is to make that a seamless kind of curriculum between both of the sites, so that they get a really robust training, with a focus mostly on spending as much time in their rural setting as possible. So we obviously are working to build our faculty so that the residents have just really good support and strong academic ties. So we want to emphasize the full spectrum family medicine. So they're going to see and experience the outpatient continuity of care, inpatient medicine, emergency, and procedural skills. And really that can be tailored to the needs of the community. And so if there is a gap in some sort of procedure that a family doc is able to do, that's potential that we can fill that gap for them. So ACGME requires that the rural track program residents spend 51% of their time or more in their rural setting. And so we, as we made our block schedule and went through and are picking where our residents are going to be able to do their rotations, that is what we're keeping in mind, that at least 51% of their time, hopefully a lot more, is in their rural site. And so what we're going to do is integrate our rural track residents with our Phoenix residents, because obviously we're one big happy program. And so we'll have integrated didactics, we'll have an integrated wellness curriculum, faculty meetings, faculty development opportunities. And so that is something that just because we're separated by some distance doesn't mean we're not going sharing all of that together. And so this is our block diagram for Mariposa that we sent to the ACGME and got approved for our official rural track programs and the complement increase. So we are ready to go. But this just kind of highlights the yellow is the rural sites. And so our goal is to have as much yellow up here as possible. So we kind of counted it up. You probably can't see it, but like total across all 3 years, it's about 65% of the time the residents will be spending in and around Nogales specifically for this block diagram. And we will work on one for Globe. And so that's the next step for Cobra Valley, is to make something like this and figure out all of the rotations that they can do in and around Globe. So for continuity clinic, obviously clinic is the heart and soul of family medicine, right? This is what we do. So being at the rural site for all 3 years is going to really support the longitudinal patient panel, the relationships that the residents form with their patients, and hopefully then we'll stay on and continue that after they graduate. So that's why we're going to have, an emphasis on the relationship-based care that will be modeled by our faculty, a focus on population health, because that's huge in rural communities. I said earlier that rural communities have a higher burden of chronic disease, so we want to make sure that we're focusing on population health and chronic disease management. And we want the residents to become our core providers in their communities. The inpatient experience goal is to have them at least do some of their time in the rural hospitals, because that is where your patients are going to be admitted if and when they need to be hospitalized. And so the family medicine theme, if you haven't gotten that by now, is continuity of care. And so I stress that to the residents and to the other docs in the hospital here, is that the reason family medicine exists in the hospital is for continuity of care. We take care of our patients in the clinic, we take care of our patients in the hospital, and then we send them back to our colleagues in the clinic. So continuity across the settings, that's the goal. So really want them to spend some time in their rural community hospitals. They admit their own patients. It will be more of a one-on-one kind of model with an attending. They're not going to have a huge group of like a resident team there, right? Because there's only going to be 2 per year to start with. And so they'll be more one-on-one with the attendings, which actually brings great training, because that's a lot of, individualized time that the residents are going to be able to spend with the hospitalists. In the urban setting, obviously we have a higher volume, and so this is where they will come to get their numbers. If needed, we'll kind of gauge that over the years and see how many patient numbers they're getting at the rural settings. But they'll likely do ICU here. And here, obviously, we've got a resident team model. So we've got 4 residents on a team at any time, and then the attending. Some students sometimes a pharmacist if we're lucky. And so the model is just a little bit different. It gives them just a little bit of a different feel, but both equally as important for their learning. Can't talk about the rural track kind of setup without talking about all of the requirements that we had to consider as well when we were building all of this. And so there's ACGME requirements, and then there's the American Board of Family Medicine requirements. And so this is a nice chart that that I made when I had to put together all of the things that we needed to make sure that the residents were going to get. So you can find this is boring, but all important. So access to the continuity of care in the clinic time, how many patients they see in the hospital, how many PEDS patients they see, how many ED PEDS patients they see. All of that has to be counted. OB deliveries, so all of that. And so we took all of this into consideration when we were kind of forming these rotations to figure out where is the best place for them to train. New in 2027, it was going to be 2026, and we're very, very happy that the ABFM pushed it back a year. I'm sure you guys were happy too. And so the procedure requirements will be required for the graduates of the 2027 class to show competence in all of these procedures. This is important really for the rural track too, because a lot of these things are going to be only family docs will be able to, you're going to have access to family docs to do these things rather than sending them to a specialist maybe to do some of these. So POCUS by 2027 as well, we're working on that. And so these are for next year, which will be our first class for our rural track. So didactics, talked a little bit about that earlier, that we'll integrate them. So we will share them. Obviously, we're not going to make our rural people create a whole curriculum of didactics on your own. And so we can have the shared core curriculum with the Phoenix people. We can do it, obviously hybrid, in person, and virtual. So if there's a workshop or something like that, and if they can easily come to Phoenix, obviously they're going to be welcome to come to Phoenix and participate in our hands-on workshops. Otherwise, they can participate via virtual settings. Our didactics already include evidence-based medicine, quality improvement, patient safety, but we'll start adding in our rural specific topics. This is important too. I've got at least one of my graduates this year going into rural practice. So from Phoenix, moving to rural Washington. And so just because they train here in Phoenix doesn't mean they're not going to go to a rural site after they're done.
My role here is, I don't know what my role is. I do a lot of different things. I came to Phoenix actually as the program director for the Phoenix Creighton program several years ago. And then a couple of years ago transitioned into a role more with the medical school, but I still am core faculty at the residency program too. So, which is really where my heart still is. Now, don't tell anybody that I work with at the school that. Yeah, but my heart is still, as quirky as it is, it's at South Central at our residency program there. And I admire you for being interested in and practicing rural practice. Residency here in Phoenix, and honestly, that was my plan when I left residency, was to go into a rural area. My wife is from a small town, and we thought, oh, that'd be a great kind of practice. And we ended up in a kind of suburban practice, but it was a small community hospital where I did really everything that most people in rural practice do. I admitted my own patients. I did OB for several years. A lot of the procedures that you mentioned up there, I did in practice. And so it's a great kind of practice. It really is. I'd go to the store and I'd see patients there all the time. And sometimes that's good. And sometimes it depends on what they wanted to talk about, It's like, yeah, I'll send you that diflucan prescription another time, okay? So along the way, though, got very interested in teaching, spent several years as core faculty and then as a program director, and now have the opportunity to work with our students. And the other hat that I wear here is a co-director of our faculty development fellowship, actually. And so as we get faculty that need to be trained and everything, that's an option too, to be part of our faculty development fellowship, or there are lots of other opportunities to learn how to teach, because it's interesting that you go through all these years of training, but being able to teach is not really part of that training. And it's not always intuitive. How do you take a resident or a student, really, who's excited about medicine and help them to become a practicing physician? And as you know, it's quite a journey. And it doesn't happen overnight that a physician learns to be a teacher. We're just not trained to do that. So I'm glad we're going to take a few minutes and talk about that today. So let's see. Oh, okay. Okay, technical difficulties, just a second. I'm glad she's doing that. I hate the technical part. Okay, so this is what we're going to talk about learner supervision and some teaching basics. And these things, it's really the same topic, I think you'll find. So this is what I want to do, and we have, let's see, what time am I done? Oh, what time's lunch coming? Is it going to come early? Okay. Okay, here's our agenda, and you'll see why I asked about lunch, because it's on the agenda. First, we're going to discuss models of competency and skill acquisition. I know this sounds super boring. It's actually pretty cool. Second is review the ACGME and Medicare regulatory requirements and resident supervision in primary care. That sounds boring, and it is. Then there's practice precepting micro skills from a clinical teaching scenario. This is where we're going to spend most of our time. We're going to take about 10 minutes and go through the regulatory stuff. And I really want to talk about what does this look like in the clinic. And this is not going to be me lecturing. We've got people that are teachers here, and so I want to hear from you. And then the important thing is to be on time for lunch, okay? Anybody remember this? Yeah, okay. So when I was a resident, I'm going to age myself just a little bit. When I was a resident, this was a big show, right? ER. And okay, look at that picture and tell me what similarities you see to residents today when you look at him. 5 o'clock shadow. Yeah, been working long days. Back then it was even longer. It was a day and a night and a day most of the time. Yeah, tie's a little relaxed. Absolutely. But still wearing a tie. Still wearing a tie, right? It's got the stethoscope there. I don't know if he knows how to use it, but it's hanging around his neck. And so you can walk up to any nursing station and they think, okay, this person's official. That's usually how we use the stethoscopes. Okay, now, have you seen this show? Few years down the road, what's the difference? Little gray hair, few wrinkles, a lot more experience, presumably, right? I don't know if he really has more experience. He's got more experience acting. You guys get more experience in medicine. You notice he's wearing a hoodie now? The tie's gone. Isn't that amazing? The tie's gone. So now he's more comfortable in his role as a physician. He's probably a little more cynical than he was, and certainly has learned a lot through this time. Okay, this is the ChatGPT version of your journey through medicine. And the goal is to go from supervised practice, which is what a resident does, to unsupervised practice, which is what happens today. You guys graduate, and all of a sudden you look back there and there's nobody behind you. It's just you that's out there seeing patients. So I put into ChatGPT, I said, make me a graphic of a resident who's on the journey from supervised practice to unsupervised practice. And this is what ChatGPT came up with. Your job is to find the mistakes. What's wrong with that picture? He's going the wrong way. Don't always rely on ChatGPT for patient care, okay? And even if he was going to the right way, where is the journey leading? It's not to the hospital, it's to home, which is kind of interesting. Anything else you see that's kind of odd about that? What's hanging on that supervised practice sign? That's where his stethoscope is. I don't think it's going to do anybody any good there. So I made the graphic to show that that's the journey, is to go from supervised to unsupervised practice. But, the little mistakes that are in there actually are kind of a learning experience in and of themselves, because that's why people need supervision. It's not enough to have time and training to be a competent physician. Those things are not equal. 36 months does not equal a good family physician. And supervision is really an important part of that learning process. So all these little mistakes don't happen, and that they're headed in the right direction and not away from. We're going to just assume that that road keeps going away from home and around the corner and back to the hospital or something. Okay, does anybody have any musical talent in this group? Is anybody playing an instrument? Okay, I see some hands. Whoa, wow, we hit the jackpot. We got a lot of people that play something. Very good. So you notice in this picture, we've got this little girl learning to play the piano. And I love this picture because you got the teacher, who we don't really see, but hands on the piano. Very active teaching happening here. And the goal is to get to here. This is the unsupervised practice. This is the expert in piano playing. And I want you to think for a second, those of you that have had some musical training, if you were taking piano lessons as a kid and your piano teacher said, I want you to go into this soundproof room, nobody's going to hear you, I want you to practice that concerto, and then you come out and tell me how it went. What's your result? What's the result going to be? Well, you don't know because you didn't hear it, right? And so supervision is really important, because medicine is really, it takes hands-on practice, it takes hands-on teaching, obviously, in order to do it well. Okay, here's the part that sounds boring, but it's really not. It's really cool. This is called the Dreyfus model of skill acquisition. Anybody seen this before? Does this look familiar? This is when, and this is not actually specific to medicine, but it fits really well with what we do. And so the ACGME has taken this, and really what we do with the ACGME milestones and everything is kind of built on this as part of the foundation. So people start out as a novice. They don't really know what they're doing, but they have all that enthusiasm that you saw with Noah Wiley when he was on the ER show, right? And they want to learn, and they're just starting out on that journey. And then they become an advanced beginner. They become competent, proficient, to expert. I want you to take a second now and think with the continuum from first-year medical student, or let's say third-year medical student, starting really more in the clinic, to third-year resident. How does that progression relate to this chart? When you start as an intern, where do you think you are in a residency program? Would you guess? Proficient, competent, novice? You're somewhere between novice and advanced beginner is really what it is. And hopefully by the time you finish your internship, you've gotten through the advanced beginner and you're starting into the competency phase. And really the goal, honestly, it is a third year that graduates, is somewhere between competent and proficient. And expert is usually somebody that's been out in the field for several years and has a lot of experience. These are the ACGME competencies, and you've got to know these in order to know where your learner is on the pyramid. There are 6 of them. Patient care and medical knowledge, practice-based learning and improvement, systems-based practice. Nobody knows what those 2 are, but they're actually really important. Professionalism, interpersonal skills, and communication. I intentionally highlighted the last 4. Why do you think I did that? And this is the what am I thinking question. What's different about those 2 than the other 4? The answer is everybody kind of can define those. The others are harder to define, and they're harder to supervise, and they're harder to give feedback on, actually. When we think about residency training, we usually think about patient care and medical knowledge. Can this person read an EKG? Can they admit a patient, do all the admitting orders and everything? We don't think about how are they doing with systems-based practice? Can they work within the health system? Can they use the EMR? Can they cooperate with their staff? Do they know how and when to refer a patient? Do they know how to call another attending and say, hey, I have a concern about this patient? Can they work with their MA? All those kind of things are systems-based practice. Nobody wakes up in the morning and says, I really want to be an expert in systems-based practice. They say, I want to be an expert with medical knowledge and patient care, but you can't do that without the others. So I highlighted those other four because those are the forgotten competencies. That as you're a preceptor, which is what we're going to talk about now, you've got to make sure that your learner is developing in all of those ways. And they don't develop all at the same time. So most people, when they start out in school and then they match into their residency, they're actually better at professionalism and interpersonal skills than they are at patient care and medical knowledge. If you think about it, we kind of select people that are already good communicators, or they wouldn't get into med school, presumably, they wouldn't get into your residency. So their life experience brings some of that already. Same with the professionalism. If they weren't able to get tasks done, if they weren't able to relate well with other people, they probably wouldn't get where they are. Now, that doesn't mean there's not room for growth, because there's a lot of room for growth. But the first part of residency, patient care and medical knowledge grow really quickly because that's where the deficit is. And then once you get to that kind of competent, maybe not quite proficient, but competent part of the pyramid, then you start to really see, oh, systems-based care, now they're understanding the system, and now you see that one really to surge. And professionalism, as it relates to their colleagues, surges a lot. The interpersonal skills is something that grows throughout their whole residency, but we don't expect them to grow at the same time at the same rate, okay? But they're all really important. So this is called Miller's Pyramid. And this is how we evaluate people towards those competencies. So at first, down at the base of the pyramid is that they know something needs to happen. For instance, you know what an EKG is, okay? You learn that as a first-year med student. Our first years just finished their cardiology block, so now they all know what an EKG is, and somebody went through with them and talked about ST segments and P waves and everything. But can they read one? Not quite yet, right? But they know what it is. They know how is when, okay, if I take a test, I can get the right answer. I can pass step 1 or step 2. And if there's an EKG and I have enough time, I can probably kind of figure it out and get that question right. Shows is when, as a preceptor, they come to you and say, I just got this EKG, can we go through it together? Does is when you have the third-year resident that says, you know, Mrs. Smith is having chest pain. I already got the EKG. I'm coming to precept, and I think it looks okay, because they've already done it, and they do it consistently over and over. So that's kind of the journey through competency and what it looks like in a specific skill. This is the challenge for supervision. It's always finding the right balance. So the balance scale there is pretty balanced now. What's on each side of it? It's these things. It's patient safety, because as a preceptor, this is your most important duty, to make sure that the work is done and it's done in a safe manner and that patients are taken care of. If patient safety is on one side, what are you balancing that with? What do you think? Throughput? Okay, so like the efficiency in the clinic, is that what you're thinking? We probably should have 3 things on the balance scale, because that one's actually really important. That's not what I had in mind, but that's very important. Yeah, in a learning environment, that's what it is. It's learner autonomy. So you've got patient safety, learner autonomy. How long is the leash I'm going to give this person? How much room am I going to give them to operate and make sure that they're safe? And actually, really, we should have this balance 3 ways, because then you've also got the system. You've got, is what I'm doing, teaching this resident, taking care of the patient, working in the context of the clinic or the hospital also. This is former administrator talking over here. Thanks, Rex. Good. So this is the part that really is boring. We're going to go through it quickly, but it's really foundational to what we're going to talk about next. So this is what the ACGME says. This is the definitions of supervision and how it's supposed to happen in a residency program. It's all about graded authority and responsibility for patient care. So when you start, the supervision is very tight. When you're about to graduate, you know, for my 3rd-year residents right now, If they don't know what they're doing and they're going to graduate in 2 months, we've got a big problem. And so my leash is a lot longer. I give them a lot more room to operate because now I know them and I trust that they know what they're doing. We're still going to talk about some things, but usually they know what they're doing. So it's based on each resident's level of training and ability, as well as patient complexity and acuity. So if I have a third-year resident who's treating strep throat, then they probably know what they're doing. Although it's funny, and you guys, I don't know if you've seen this. This is something that faculty see every year, is that you have third years who haven't wanted to precept for a long time. They're like, okay, I got to go precept. And in the last few months, they come in precept and they're like, okay, now what's the dose of amoxicillin again? I got to do this on my own pretty soon. Because then they start to get just a little worried that they have autonomy staring them in the face. They're about to go out on their own. But the idea, of course, is that they get more autonomy as they earn it. It's not just because they are a third year. It's because they've earned it through demonstration of competency. There's two levels that are really important for family medicine of supervision, according to the ACGME. There's direct supervision, which means that you as the attending were physically present during the key portions of the interaction. Does that mean you have to sit and listen to the whole interview? No, not at all. They're past that. That's a first-year med student doing their clinical skills. But you do physically see every patient. And you may choose to perform some of the physical exam yourself. It may be that the key portions were talking to the patient or asking the key questions, and that's what you redo when you go back into the room with them. So they've got some room to operate on their own, but the attending has to be physically present and certify that what happened in that encounter is correct when it's documented. And then there's indirect supervision, which means you're immediately available for direct supervision. So the resident saw the patient, they made the decisions, they did their thing, whether it's in the hospital or whether it's in the clinic. You're in the preceptor's office, you are immediately available, but you may not necessarily see the patient. So that's indirect supervision. You know what's happening, you've reviewed the chart, they've talked to you about it, but you don't necessarily see the patient. And in primary care, there's an exception. Not all specialties get the privilege of doing it that way. But in primary care, it's really important because we want our residents to have continuity with their patients. They're the face of the care that's given that day. This was the hardest thing for me when I left regular practice and came into a teaching situation, because the fun of family medicine is the relationships that you have. And now you have to step back a little bit and say, oh, it's the resident's privilege to have that relationship with the patient. And so I'm going to let them do the talking, but I'm going to make sure that things happen right. Okay, does that make sense? Okay, good. Now, Medicare. This is the part that's really boring. It sounds boring, it is boring, but we're going to just have one slide on it. So Medicare guidelines, we got to obviously operate within the guidelines. And so the first is the attending physician must provide direct supervision, so you see the patient during the first 6 months of training. So first half of internship, you go back in the room with every single patient. That's in the clinic. So in the clinic, we have what's called a primary care exception, which allows residents to do a little bit more. In the hospital, that's different. That primary care exception only happens in your office. So if you're doing rounds in the hospital, the attending physician actually has to see every patient every time. Again, they don't have to do all the work, but you have to see every patient every time. Second, attending physicians must provide indirect supervision for residents who have completed more than 6 months of training. So after February 1st of their first year, now they can go in and take care of, Mr. Jones with his cold, and you don't have to see the patient. Okay, they're giving the care. You're supervising it. You're ultimately responsible, but they can actually be giving the care. And attending may not precept more than 4 residents at a time. Now, in the rural areas, that's probably not going to be an issue. We have that happen all the time. We have to look at the schedule and say, oh, we got 1 extra resident today, so we're going to have 1 more preceptor, because that's what Medicare makes us do. And you guys all know that if Medicare says that, all the other insurers follow suit. And so if it's a Medicare rule, it's kind of a rule for everybody, basically. Medical records must document the extent of the teaching physician's participation in the review and direction of services. So in your note, you have to say either I was physically present or I was not physically present for the most important parts of the encounter. And then I try to add on, although sometimes I don't because things get super busy, but I try to add on something about what I added to that encounter. So you can use any kind of, in Epic, it's a dot phrase. In Cerner, I can't remember what it was. There's a similar thing where you can, with a few keystrokes, you can put your attestation in there, but you may choose to add just a little bit more to say, we talked about why this person shouldn't be on lisinopril. They should be on amlodipine instead. So you're showing the added value that was given because you were the supervising physician. And that's good practice to do that too. And then the last bullet point there isn't really a Medicare thing, but it's a practical thing that individual institutions might have additional policies about what a learner can or can't do. In some institutions, they don't have that. And I don't know if that's written into, for instance, the hospital bylaws in Nogales or in Globe, what a learner can or can't do. Like at Valleywise, even if in our clinic, even if the resident sees a patient and can do that autonomously, we still have to write a note. That's actually not true at every institution, but it's pretty common. It's good practice to do that. Okay, last thing with Medicare. So these are the allowed services that you can do under the primary care exemption. So new patients 99202. Oops, that should be to 205, not 203. Oh, no. Wait, I'm reading it wrong. So these are the allowed services where the resident can do it on their own without supervision. It's just a 202 or a 203 for a new patient. And then a 211 to a 213. So in other words, if the level of service is 204, 205, 214, 215, then you need direct supervision. The attending has to see them. Now, what that means is up to you as a preceptor. If you trust the resident and you see them walking down the hall and you say, they're fine, I trust the resident, that's up to you. But what the guideline really says is that you should be there for the most important part of the encounter. Now, honestly, a lot of times when I go back in the room, to me, the most important part was maybe one question that I wanted to clarify. And as long as you are doing what you feel is the most important part and you document that, that still is direct supervision. And then there are these, and then Medicare wellness exams can be done unsupervised after the first 6 months. So they're like a 211 to a 213 level. And then there are these two modifiers that need to be put on. We're kind of fortunate actually that, in fact, most places I've worked at larger institutions, the billers kind of do that, and I forget to do it. Somebody on the back end that does coding adds this for me. But it's a GE modifier for indirect supervision, GC modifier for direct supervision. Medicare makes you put those on. The other insurances, companies don't really care about that, but for Medicare, that signifies that you follow the rules, basically. Okay, we're going to pause there. That's the part that's boring. Hopefully, I'm making it sound like the next part's going to be fun. I hope it is. We'll see. Any questions about that? Yes. Yes, good question. And Medicare always, when we look at the Medicare rules, we always are kind of thinking about adults and the codes that apply to adults. But yes, well child would be the same as like a Medicare wellness exam. They can be done unsupervised. Yeah. Procedures, always direct supervision. Even if it's in our clinic, even if it's like freezing a wart or something that's really low risk, typically the attending really should be there. Okay. Medicare probably won't pay for it unless you can document that you were there. Anything else to that point? Super cool, isn't it? Isn't this cool? Don't you love Medicare? This is probably one of the places where Medicare is the most straightforward, so we were thankful for that, right? Okay, takeaways. First of all, look at the picture. Tell me who the coach is. Anybody know? We'll see how old you are, how good your memory is. Rex knows who this is. Tell us who the coach is. John Wooden, absolutely. Probably the best, most successful coach in basketball, NCAA history. He won, I think it was 7 national championships, if I remember right, with UCLA, coached some of the best players ever. It's a few years back, so sometimes people don't know him now, but he was amazing. Look what he's doing in that picture. He worked with people like Kareem Abdul-Jabbar, one of the best players ever. So he coached these people that are amazingly talented, but unless they had a coach, they would not have won championships. So remember, everybody, even the stellar residents, need a coach, right? And he's in there with them, working with them, coaching. It's hard work to be a coach. And that's the takeaway with supervision. It's hard work to be a good coach. So supervision is not just about the regulations that we just talked about or the billing requirements. That's the foundation. We have to get those right to stay in business, to be safe, but it's really about learning and it's about patient care at the same time. So it's that balance between learning and patient safety that you're always trying to kind of keep in balance, and the system too. Keeping all that in balance is the preceptor. And ultimately, no matter what Medicare says, or no matter what anybody says, you're responsible for the patient and the learner. And so you decide how much supervision the learner needs. So just because it's January 2nd of the first year and they've got 6 months under their belt, that doesn't mean you don't go back in the room, because you might, really, there's no magic that happened between December 31st and January 1st there. It's a rule, right? So if the resident needs some help or you feel like you can add value, by all means, go back in the room with them and make it direct supervision. That's really important, because it's going to go back to those competencies we talked about. It's not all medical knowledge and patient care. Sometimes it's communication. Maybe the resident got all the answers right, but you can tell that something in the way that was communicated to the patient just sounds a little, I'm not sure about that. So I'm going to go back and make sure that happened correctly and model those behaviors and those competencies. Okay. This is where we're going to spend the rest of the time. We got till, was 11:30? Okay, good. We got plenty of time then. We'll probably be done early because lunch is really that's the ultimate objective, is lunch. Scenario 1, this is like every patient in our clinic, literally every patient in our clinic. So this is a PGY1, month 7 of residency. So we're into January of residency. Can in some cases now be unsupervised or not have direct supervision. Sees a 66-year-old patient with hypertension, diabetes, stage 2 chronic kidney disease for a diabetes follow-up visit. How many times a day do you do that? It's like, that's half of our schedule, it feels like, right? Patient feels like she's doing well. She's great. Okay, this is scheduled at 10 a.m. That's important because of your role with the system. Like you said, in the efficiency, it's really important. So her hemoglobin A1C is 7.2%. Yeah, she's doing, that's not bad, right? That's pretty good. When we, in our clinic, I don't know what it's like in Globe or at Mariposa, but if somebody has a 7.2%, I'm like doing cartwheels. That is so exciting because we have so many that are like 12, 13, 15%. And I'd say, this patient, this is great. Sure, do whatever you're doing. You're doing great, resident. Go ahead and do it. She also has a sore throat and a cough, by the way. So at 10:53, remember it was scheduled at 10 o'clock. 10:53, this resident comes to you to precept the patient, and we're going to assume the resident has an hour with the patient. Actually, in our clinic, it'd be more like 40 minutes, wouldn't it, at this point? So maybe falling a little bit behind there. His presentation's a little rambling and difficult to follow. Anybody ever heard that before? This is probably me when I was in it. This is probably me when I was a 3rd year. And he spends most of his time talking about the patient's diabetes and fails to notice that the blood pressure today is 179/98. That's a problem, isn't it? Ignores the cold symptoms completely, when that's what the patient that's the patient's agenda. She knows her A1C is okay, but she's feeling sick today and she wants to talk about that. So ignored that completely. Also notes that the patient is upset and in a hurry. Wonder why. We're almost an hour into this encounter. So questions for discussion. What problems do you see with this encounter? You as the smart preceptor, the coach, let's just list a few problems with that presentation. not addressing the acute complaints. What's really too important to the patient? Ignored that one, right? How many times have you seen this happen? Oh, well, you got to come back and talk about that next time. Now, sometimes that's important and because you got to be efficient, but that's what she really kind of came in for, is she's sick and she wants to feel better. Okay, what other problems do you see? Good, good. Yeah, not only did they not even see the first one, but there wasn't even a second one done. Yeah. How often do you guys, when you're precepting, notice this can happen that, oh yeah, you did a great job, but nobody looked at the vitals. The vitals are vital because they're vital, right? Anything else you see that's a problem? If you use the preceptor, what do you want to fix? And the answer can't be everything. Yeah. Interpersonal skills. That's one of the competencies, isn't it? Did you find out why she's upset? What's going on? Yeah, really important. Anything else? Use the preceptor, got to fix all these things. I think those are probably the biggest things. Yeah, that's a big problem, isn't it? Oh, yeah. Well, why were you in there for 53 minutes and then you didn't even talk about the cold? And the A1C is fine. So all you had to do is refill that metformin. That wasn't hard. What was going on in that room? Okay. What ACGME competencies do those problems fall under? Kind of gave you one that could fall under interpersonal skills. What about being late? Which ACGME competency does that fall under? Now I'm testing your knowledge because they're not right in front of you. Professionalism could be part of it. Yeah, professionalism certainly could be part of it. I heard somebody say systems-based practice. Yeah, are you efficient? Are you able to keep the office running? That's a really important thing, right? So definitely really could be either or both of those. What others? Is there any other blatant professionalism problem here? We don't know because we weren't in the room. Nothing that seems obvious. But we don't know what they were talking about for 53 minutes. Okay. So you can see as a preceptor, though, you've got to look at that. It's not just about medical knowledge. Oh, you didn't notice that blood pressure, which is really kind of patient care, I guess. The resident probably knows that that's an abnormal blood pressure, but did they integrate it into the patient care? Absolutely not. So there's a patient care issue. Okay, so as the preceptor, which of those do you want to tackle? You've got the patient's already upset because things are running late here. You just have a few minutes. What's the most important thing? Yeah, probably so. Yeah, the blood pressure, definitely. And then if the patient wants their cold addressed and you ignored it, yeah, you probably ought to do that, because if you don't, you're going to have a really upset patient. So yeah, probably need to take care of those. What about the issue of being on time? Is that important? Yeah, it is. But if you sit and give the resident a lecture right now about it, what happens? They're going to be later. And so that's where you have to prioritize, right? So you got to pick and choose and say, I can't fix everything in 2 minutes here. What's the most important thing? Maybe you pick up some of those other things later, or maybe you just note it and you watch the trend. At some point before that resident graduates, you want all those problems to be worked out. But does it have to happen in every single encounter? Not unless you want to drive yourself crazy. Okay, because really you can't hit everything that needs to be done probably, and really help that patient or that resident to learn it in just one encounter. So sometimes you note things and you say, okay, we're going to watch and see if this resident's late next time. And when it becomes a trend, then we're going to deal with that one. Okay, what questions do you want to ask the learner? So they do this rambling presentation. What else do you want to know? And I'm not talking about, well, what is the physical exam, but what things were missed and what kind of questions would you ask to figure them out? Yeah, yeah, that's a big one, isn't it? How would you ask that as a teacher, not just as an upset attending? Good, good. I think that one you can just be straightforward about and just ask it. What about the issue? Oh, yeah. Uh-huh.
I would want to ask them, are you okay? Like, what's going on? Because it's out of the norm for them.
Good, good. I love that. And I'm going to quote Heather Walker here. Some of you know Heather Walker. She um, supervises our sim lab for our students and our residents. And if you've ever done anything in simulation, one of the techniques of giving feedback is called advocacy inquiry. Basically, you want to ask why. You got to, unless if you're going to correct something in somebody's thinking and help them to acquire a competency, the first thing you need to do is figure out why did they not meet the competency that time. And so the appropriate question is probably, what are you thinking? You're 53 minutes late. It's, you're usually a little more efficient. Tell me what happened. Tell me what happened. I would have expected you to be here sooner. Even that's a little, I would have expected you. Something's different. Tell me what happened and find out why. It's a good way to get at that. Anything else as far as questions you want to ask? You can probably think of a million things, did they have any medicine side effects? Are they taking their medicine? Are there any, all the medical details come easily to your brain, but think about the other competencies sometimes, like why were you in the room so long? Tell me how the communication went with this patient. Those take a little more thought, but they're important questions. Okay, as a preceptor, do you need to go supervise this? Do you need to see this patient? Okay, so I see some heads nodding. Why? This is month 7. They can go with indirect supervision, right? Technically, but why would you want to see the patient? Ah, good, good. And we're not going to get into billing, but just that blood pressure alone, no, that's probably going to be 214, and you should walk in the room. Yeah. Did you? Okay. Let's say billing wasn't an issue. Yes. Yeah.
Like, that are labile, and many young learners, when there's strong emotions in the room, they kind of just like deer in headlights. So, and they also struggle with how to redirect the conversation and get the patient back to what their agenda is.
Good. Good. Excellent. That's a really important thing to pick up, I think. Yeah, you should go in the room because the system's going to want you to bill this correctly. That's a really important thing. And Medicare says you need to be in the room if you're going to bill a 214, and that's important, looking at the number of problems and everything. But for that resident's education, what you said is really important. This is where you become a coach. And maybe you can do this without, or maybe you can down code it and do a 213. Well, okay, we do that sometimes. When you get busy, it does happen sometimes. But yeah, what's going on with the communication in the room? What's going on in this resident's mind? And granted, we're a little behind in this encounter, so you can't spend a lot of time on that. But what you said is so important. And when we're working with learners, one of the big objectives always starting as a first year med student, I work with our first years in their very first clinical encounters, and we ask them to start presenting a patient. And you know how you do it. You're going to start with the chief complaint and you go through the HPI, everything in order, right? And if they, instead of doing this, if they do this, what does it tell you? It's not just about their communication, although that's a big part of it probably. It's about their thought process, that they haven't figured out that systematic thought process. That presentation is a window into their clinical reasoning. And so you got to kind of find out, how do I help this person? And that's something you're probably not going to fix in one encounter. But when you watch a trend and you see, hey, this resident, they seem to get to the right place eventually in that journey. But it's like the ChatGPT version. There's lots of little mistakes in there, and then they end up where they're supposed to go. Let's help them to do this. And then they're going to be more efficient. We're going to know that they're getting the right answer because they know what the right answer is and they know how to think through it. And the value that you add going back into the room is you're showing them how to do it. It's like when you're in school, did anybody ever have, like in elementary school and you're doing math and you can pick out the right answer from multiple choice answers, there are questions, but then they say, show your work. And it's a much bigger deal, isn't it? Well, as a preceptor, the way you teach clinical reasoning is you show your work, is you say to the resident, that was great. Let me show you what I would have done. Or you go back into the room and you ask a question in a different way so that they watch what you're doing and they're going to model after what you're doing. Okay, so that's really, it's important to remember that whatever you're doing, you're teaching. It's not just about getting the right answer with medical knowledge. It's about how you go about it, and they're watching that. And as you model it and show your work as the attending, they'll get it. Okay, any other reasons you want to go back into the room? Yeah. So there may be some questions that you want to get, and it might be as simple as, well, did you ask if you took your lisinopril this morning? And you go back in and you very tactfully ask that without embarrassing the resident. But hey, we noticed your blood pressure was high, and we just were talking about it and wondered, did you have a chance to take your medicine today? Or there might be some professionalism modeling there for the resident too, just to kind of say, those vitals are so important. And sometimes I miss them too, but I try to get in the habit of every time I look at an encounter, that's where my eye goes first. They're like, oh, yeah, I didn't do that, did I? Okay, next time I'm going to do it that way. Yep, absolutely. That's a big finding, isn't it? And that didn't come out in the presentation. And so you probably want to walk in the room and say, hey, you having any chest pain today? You breathing okay today? Just to make sure that they're safe. Sure. So the point of that is, yes, you go back in the room for the regulatory reasons that we went through, but you also go back in the room because you're a coach. And there are things that you do that with your experience, that first-year resident doesn't know how to do. And you can sit and tell them that, but it's a lot more effective if you show them that. So you really do add value sometimes when you go back with them and see the patient together and you model what it means to be an experienced physician. Okay, where is this learner on the competency pyramid? If this is the model, where are they in this pyramid? Novice, you think? Novice to advanced beginner. Yeah. So turn this around now. We've got just a few minutes left here. What would this look like if the person was competent and not novice? Let's look at the same scenario, and how do you think it would have been different as a preceptor? Yeah, good. So looking at the blood pressure, competent might be they noticed the blood pressure, they saw it was a problem, maybe that was even first in the presentation, and they had a plan for it. And the plan was probably reasonable. It may not have been what you were going to do, but it was probably reasonable. I'd say that's probably competent. And then expert was like, okay, they come to precept with you and yeah, I talked to them about the blood pressure. This is what happened. We talked about how to not miss your medicine. There's no other problem. They're not in heart failure. They're not having chest pain. Done. And you look at that resident and you say, okay, you got it. You're okay. I don't have to say anything else about that. And probably they would have, you mentioned the second blood pressure. If they're an expert, they would have already check the second blood pressure, or the MA is in the room doing it now. They've already recognized that happens. That's part of systems-based practice, that they've already instructed their MA. Maybe it was by protocol, maybe they had to tell them, but it's already happening. And when you see that, you say, okay, they're definitely proficient. Expert level actually is kind of more like when you look at population health data of your panel, everybody has their blood pressure in control or they don't, that you're doing well on even a higher level there. Where proficient is, you got through that encounter just fine. Lots of skills happening, just like in a basketball game. Being able to shoot a layup is not the only skill you need. First, you got to get the ball in your hands. You got to be next to the rim. You got to do all that without a foul. It's okay if you get fouled, but you can't foul anybody, right? So there's a lot of things happening besides just getting 2 points. So let's kind of go through, well, what happened in the preceptor's mind, or what are the things let's break that down into how do you make that precepting encounter go really well? First is what we kind of went through here, is understanding what's expected of the learner in terms of the competencies. And when you're working with a student as compared to a third-year resident, what your expectation is vastly different. With a student, it's that I can put the stethoscope in both ears at the same time, and I can know where to put it on the patient's chest. Okay, when I work with our first-year students, they just did a heart lab where they went through heart murmurs and stuff, and I'm like, that's great. But what I want you to do today is make sure you hear 2 heart sounds and that they're regular and that they're the right rate. Yeah, got it? Those 3 things. Go in and listen and tell me, is it regular in rate and rhythm according to your ears? And then if there's anything else you hear, it's abnormal, so we're going to talk. It's that basic. Where in a third-year resident, it's like, okay, what do you think that murmur was? Is that aortic stenosis? Is it mitral stenosis or whatever? Very, very different expectations. And you can't expect third-year resident outcomes on your first years. And so your teaching is very different in those 2 groups. Preparing for the encounter, I think, is an important thing. Maybe you sit and look through that resident schedule for the day, or you look through your hospital rounds list and you think, okay, we have 3 people today that had chest pain. Maybe we're going to talk about chest pain today a little bit more than the other things. We're going to get all the patient care done, but we're seeing a theme here, so let's spend some time on chest pain today because that's going to be good educationally. Deciding what you want to focus on. So you're going to look through the encounter and make sure that you know what's going on with patient care, but that you've also got somewhat of a plan for teaching. You're busy. You're not going to spend a half hour putting together a teaching plan for rounds that day. You're going to spend about 3 or 4 minutes and say, okay, I see some themes here. This is what I want to follow as we're teaching. It shouldn't take a long time because you don't have that much time. Listen long enough, but not too long is a really important micro skill. So you got that patient, or that patient, they feel like patients, that learner who's wandering around in that presenting. At what point do you just say, okay, and kind of butt in a little bit? Where's the best place to do that? Or do you sit and listen to the whole thing, 5 minutes of them going in circles? Well, I don't know. The answer is it depends on the learner. But you want to listen long enough that you're giving them some autonomy. But sometimes you gotta just say, okay, I think I got it. Let's go on. Let's talk about your problems now. So that's a real skill to learn that balance. Identifying opportunities for improvement is, okay, what did you see in there that the resident needs to learn? You're helping them set an agenda now for learning issues. Deciding how much supervision the resident needs. Do I go back in the room or not? Beyond what the regulations say, do I need to go see that patient or not? Is there value for the patient? Is there value for the learner if I go back? Working together to formulate the plan because they're that patient's doctor that day. But you are too. But they are. But you are too, right? So you got to work together. Modeling clinical reasoning, that's showing your work, showing him how it's done. Model professional behavior. Ooh, this one we didn't really talk about, but what if Mrs. Smith is really upset because that resident was really slow and she wants her cold taken care of? She doesn't really care about the blood pressure, but you do. What do you do to go back into the room? Because you're falling into a trap there, aren't you? Somebody's going to be upset. Now you can model for the resident. Well, how do you handle those situations that are a little bit charged? And then oh, by the way, at the end of the session, at the end, when all is said and done, how do you give feedback? We have something we've kind of stopped using, but I think some of the residents are still in the mode of doing this. It's called the go home card, where it's a simple card. And on one side it says, what did you learn today? And on the other side it says, give me some feedback on my performance. And they're supposed to hand that to the preceptor. The idea, though, is at the end of the day, now you're looking back at all the work they did and you give them feedback based on that. I really love the way that you interact with patients. Let's work on looking at the vital signs. We already talked about that. You got that. And then, maybe you could go and study about this. So you're giving feedback and helping them to move forward as a learner. And then, of course, you got to document appropriately. And that's that attestation you put on that we talked about. Glad you said that, Nicole, because that is really important for your accreditation, among other things, because each year in the ACGME survey, which is required, all new faculty will fill that out, all your residents will fill that out. And one of the questions is always, is there adequate feedback in what's happening? And sometimes you just want to kind of take them and say, I am giving you feedback right now. This is what it looks like. This is feedback. But it can also be at the end of the day, something as simple as, hey, that day went really well. Thank you. I enjoy working with you. That's feedback. That's very powerful feedback, actually. Sometimes that positive feedback is more powerful than the learner than what were you thinking? You didn't see the blood pressure. Come on, or they missed that, and the next time they did it right, and you say, yep, that time, that's what I want it to look like. That was perfect. Your form on that layup was so much better than on the first layup. Good. Keep doing it that way.